Hello everyone, my name is PJ Miller and I'm currently at Wake Forest. My background residency training is in combined internal medicine and pediatrics, and I've subsequently gone on to do fellowship training in hematology as well as adult critical care medicine. I'm currently the medical director of our medical oncology ICU. And I'm here today to talk about the coagulation dysregulation and thrombosis secondary to SARS CoV-2, otherwise known as COVID-19. Disclosures. I have no financial or industry relationships or interests to disclose. Thoughts and opinions in this lecture are mine alone and do not represent Wake Forest School of Medicine. Objectives. To understand the increased risk and incidence of thrombosis for patients with SARS CoV-2, and to understand the hypercoagulable state characteristic of this disease. To discuss different theories or mechanisms of the increased risk and incidence of thrombosis. To understand differences to homeostatic hemostasis. And as always, to appreciate the true complexity of hemostasis. A brief lecture outline. In this lecture, we'll discuss key terminology to understand coagulation. We'll discuss background information on SARS CoV-2. We'll discuss the background on the increased risk and incidence of DVT, PE, and thrombotic complications. We'll discuss background on coagulation. For example, how does coagulation occur? And what is the significance of a D-dimer? We'll also review different proposed theories on mechanisms of increased thrombosis. I think most people could probably relate with this slide. This is probably a perfect representation of my personal experience with digesting information and updates of SARS CoV-2 or COVID-19. By January 30th, 2020, the Trump administration restricts travel from China. February 2nd, 2020, the first death outside of China is reported in the Philippines. And by February 5th, 2020, this is when the Diamond Princess cruise ship is now quarantined in Japan. On February 7th, Dr. Li Wenling has now died after contracting coronavirus. He was one of the first physicians to speak out publicly that something was going on. By mid-February 2020, France announces its first COVID-19 death. February 23rd, 2020, Italy begins its surge in cases. By February 28th, 2020, Guan et al. Publish in the New England Journal of Medicine the clinical characteristics of 138 hospitalized patients with 2019 novel coronavirus-infected pneumonia in Wuhan, China. This is one of the first publications allowing us insight into the disease process. February 29th, 2020, the United States reports its first death. March 11th, the WHO declares a pandemic. Trump administration blocks most visitors from continental Europe. March 13th, Trump declares a national emergency. March 29th, the CDC issues travel advisories for New York, New Jersey, and Connecticut. At the same time, stay-at-home orders now proliferate in individual states. By June 19th, 2020, greater than 8.5 million confirmed cases worldwide and over 456,000 deaths. Since I gave this lecture at the end of May, there has been greater than 3 million new cases and 100,000 deaths. During this entire time, journals, media, and blogs explode with reports. So what is the purpose of having given that abridged timeline? It is to show how fast this disease process started and spread across the globe. The understanding of the words on this slide is absolutely integral to understanding the process that we are dealing with. Coagulative homeostasis is a complex, dynamic, and self-regulating microsystem modulating and sustaining balance by feedback inhibitory control. We'll talk more about this, and this statement will make more sense by the end of this lecture. Let's take a step back now and review the coagulation cascade. Most people know you have the extrinsic pathway, and it's this side of one of the arms of the coagulation cascade. And on the other arm, you have the intrinsic pathway, which involves a whole bunch of other factors. We know it's just not factor 7 because that's the extrinsic pathway. Whole bunch of stuff kind of happens. Just memorizing those two arms, get to the common pathway, and then boom, you hit factor 10. There's some calcium or something that gets thrown in there, and you produce thrombin, and that's good. That does not actually exist in real life. The majority of the coagulation cascade has been discovered in test tubes, not in vivo. This is a better representation of the coagulation cascade, mostly because it is starting to show the interactions, the feedback, and the true complexity. But this is still grossly oversimplified. This is a little bit better representation, mostly again because it shows the feedback mechanisms and the true complexity. You don't have this simplified cascade, one side intrinsic, one side extrinsic, that come together and meet in the middle. This process is constantly interacting with itself for both positive and negative feedback loops. This is probably the best example of the coagulation cascade. I was in awe when I first saw this picture, mostly because of the complexity. I had the pleasure to listen to Dr. Cohen speak at the Society of Critical Care Medicine, the annual Congress, this past year. And this slide really blew me away, mostly because of how interconnected each piece is. And when you have a disruption in this, how truly complex trying to fix the process could be. Here we have Virchow's triad, which is made up of a combination of stasis, hypercoagulability, and endothelial damage, which ultimately can result in thrombosis. There could be viewed a triad for SARS CoV-2 as well, but instead of stasis, endothelial damage, and hypercoagulability, you also have a loss of homeostatic hemostasis. You have an increase in heparin-binding proteins. You have a revved up immune-mediated coagulation cascade. And you have a disruption of fibrinolysis, therefore inhibiting the breakdown of this revved up immune-mediated coagulation cascade. So, what is believed to cause the SARS CoV-2 hypercoagulable state? Well, evidence appears to point towards several factors. Heparin resistance, which is likely due to an increase in inflammatory proteins that bind heparin, such as vitronectin, platelet factor 4, and others. You have elevated von Willebrand factor, and thus factor 8 levels. You have a disruption of the endothelium. There's an immune-mediated stimulus of coagulation. You have a disruption, if not shutdown, of fibrinolysis. And you have prolonged periods of immobility, especially when these patients are critically ill in the intensive care unit. So what is the best way to think of this process? It is not coagulopathy. This is COVID dysregulated coagulation. We can go ahead and start referring to this as COVID DysCO. This is not a true coagulopathy. Coagulopathies, historically, by definition, are bleeding disorders. This is not a bleeding disorder. This is a dysregulation of the coagulation cascade. So COVID DysCO is a better way to think of it than COVID coagulopathy. For my fellow hematologists out there, this SARS CoV-2 coagulation dysregulation is a hyperinflammatory immunothromboendotheliopathy procoagulant state. Let's talk about immunothrombosis and how this will play a role in the pathologic coagulation dysregulation of SARS-CoV-2. You have a mutualistic, symbiotic relationship between the immune system and coagulation. There is activation of coagulation that assists the function of innate immune cells. Dysregulated activation of the immune system contributes to both macro as well as microvascular thrombosis. And leukocytes express and release coagulation and fibrinolytic factors. So what does activation of platelets actually mean? Platelets exocytose granules. There's activation of phospholipase A2 that helps with the formation of thromboxane A2. You have a change in the physical shape. Development of this platelet plug with surface receptors of GP2B3A, which binds fibrinogen, therefore binding to platelets, as well as causing adherence. And von Willebrand factor receptor adheres platelets to collagen under this broken endothelium. So platelets are not these little pieces of cells or these small cells that just float around waiting to plug up a hole when the endothelium is damaged. They're very, very metabolically active. This electron microscopy further demonstrates that. To the left, you have a resting or senescent platelet, and to the right, you have an activated platelet. And everything that you see around it, this is procoagulant, platelet-derived microparticles, which are releasing chemicals, releasing signals for other cells. This can be further demonstrated on this electron microscopy. To the left, you have a resting platelet, and to the right, you have an activated platelet. And everything that you see surrounding this platelet is likely procoagulant. These are platelet-derived microparticles. This is very, very important to developing a functional thrombus. To better understand the dysregulated coagulation that occurs in SARS-CoV-2, we have to understand a little bit about the thrombogenic state. Thrombin binds the thrombomodulin on the endothelial surface, which activates thrombin activatable fibrinolytic inhibitor, otherwise known as TAFI. For example, in sepsis, lipopolysaccharide stimulated leukocytes are able to increase this activation as well. There's also an anticoagulant effect that develops. However, the process currently is shifted towards thrombosis. Thrombin now produces large amounts of fibrin from the conversion of fibrinogen. Fibrin molecules will adhere to each other, forming long fibrils for incorporation into a thrombus. This slide is from a lecture that I give on staging of DIC, and what you can see here is that in this stage 1, what we refer to as stage 1, is a prothrombotic state, and you'll have thrombin that will then activate factors 5, 8, and your platelets, and that will create additional thrombin. As that additional thrombin is created, it will now bind to thrombomodulin, and this thrombin-thrombomodulin complex will activate the thrombin activatable fibrinolytic inhibitor, therefore decreasing or turning off fibrinolysis. So now you're left with this immunothrombogenic state. And in this immunothrombogenic state, you have polymorphonuclears, neutrophils, that will mostly release matrix metalloproteinases and serine proteases from its granules. These will directly activate factors 5, factors 8, and zymogen factor X. They will also degrade natural anticoagulants, antithrombin, heparin cofactor 2, tissue factor pathway inhibitor. And remember, this is necessary because in regulated hemostasis, you want to develop this thrombus. You want to develop this clot. You don't want it being broken down immediately. You want to control the process, and this is why dysregulation and loss of feedback will result in pathology. This is just a slide to show how different cells can look once they're activated under light microscopy. It's not uncommon that I'll get consulted, whether I'm on the ICU or if I'm covering hematology and for a patient that's in the ICU, and we'll obtain a peripheral blood film or blood smear, and you'll see a lot of the cells that you can see on the right side of the screen. You'll have an increased vacuolization, you'll have changes in the granularity, whether it's hyper or hypogranularity, and you can infer a lot from this smear. There's definitely times when I've looked at a smear that the fellow is presenting, and before they're done presenting, I already know that the patient is likely in septic shock, just based on how these cells appear. And these cells and how they appear, this is all tied together with your coagulation cascade and how you develop a thrombus versus the inflammatory process and how that is contributing as well. So how do these cells interact in this immunothrombogenic state? Well, thrombin will induce chemotaxis of neutrophils and monocytes. Neutrophil extracellular traps, NETs, also released by monocytes, macrophages, mast cells, and basophils, will act as a scaffold, therefore concentrating platelets, red blood cells, von Willebrand factor. Circulating cell-free DNA will result in thicker fibers, and this impairs TPA from activating plasminogen. These NETs can also activate contact factors and can also protect thrombin by inhibiting inactivation by antithrombin protein C and the thrombomodulin thrombin complex. This slide is a good representation of how extensive these NETs can be and how wide they're able to stretch from its point of origin. Also included in this immunothrombogenic state are histones, which are cytotoxic to endothelial cells, and along with cytokines, high mobility group BOX1 and granular enzymes will increase endothelial tissue factor. There will be an exocytosis of Weibel-Palade bodies, therefore releasing von Willebrand and P-selectin. Cytokines and generated oxidants will impair ADAMTS13, thus providing a network with enhanced platelet binding abilities. P-selectin will increase leukocyte receptors as well as binding GP1BA as well as GP2B3A. Quiescent or sleeping leukocytes, i.e. not activated, will promote and maintain blood fluidity. For example, natural anticoagulants such as endothelial protein C receptor, thrombomodulin, tissue factor pathway inhibitor. When activated, these leukocytes provide a site for coagulation factor assembly as well as activation. The upper image in this slide is a good representation of how different disease processes can have varying degrees of thrombosis as well as inflammation, and those disease processes that really have a significant overlap between the two. The bottom part of this slide is a good representation how all cellular elements, the platelets, the neutrophils, the red blood cells, how they can all be interplayed and interlinked, in that regardless of which disease process is causing this thromboinflammation, the occlusion and the end organ damage seems to be the most important aspect. This slide is a good representation of the antithrombotic function of endothelial cells. Many people assume that endothelial cells line the inner border of a piece of vascular tissue. However, as you can see here, there are many proteins and anchoring binding proteins that are involved both in the antithrombotic function as well as sites for where coagulation can occur. When you have a disruption or a altered feedback in some of these processes is now where you get an uncontrolled either coagulopathy or uncontrolled coagulation. This is another great example of how when you have injury to the endothelium, you'll release reactive oxygen species or inflammatory cytokines, and how bacterial endotoxins can also play a role in releasing a lot of these inflammatory markers. How your leukocytes will now become active and interact with your endothelium through tethering and adhesion, and releasing their granules as well. And how this all further promotes this hypercoagulable state, especially if left uncontrolled without that negative feedback mechanism, either because it doesn't exist or because the process is now dysfunctional. Earlier in the presentation, we talked about heparin binding proteins, and vitronectin is one of those heparin binding proteins that potentially is increased in this state of massive inflammation secondary to SARS CoV-2, COVID-19. Vitronectin has a role in stabilizing plasminogen activator inhibitor, PI1. It inhibits the plasminogen conversion into plasmin, and it protects thrombin from inactivation by a heparin antithrombin complex. And you'll also have decreased fibrinolysis. This has the potential to produce a state of heparin resistance. This slide is also adapted from my lecture on staging of DIC, and this is overall how I visualize a simplified version of DIC. However, in SARS-CoV-2, this final stage, stage 3A and stage 3B, where you have this overactivation of TPA, creating lots of plasmin that'll degrade fibrinogen, fibrin polymers, your cross-linked fibrin, all the clotting factors, your platelet surface receptors. That doesn't seem to be happening in SARS-CoV-2. So you don't seem to actually shift into a state of DIC commonly. Now, there probably are patients with SARS-CoV-2 that do develop DIC, but it does not seem to be a common presentation. Either patients that are not hospitalized, patients that are hospitalized on a general medical ward, or patients that are hospitalized in an ICU. I can speak to that from case presentations, from different publications that have been made available, as well as just personal experience of being consulted on the general wards, as well as managing these patients on my service in the ICU. They don't seem to enter into this DIC, this bleeding diathesis, even if their coagulation markers are disrupted early on, similar to what we would see in certain stages of DIC with a prolonged PT and or PTT. I've always been a firm believer in DIC, disseminated intravascular coagulation, having a very wide spectrum, and that on one end of the spectrum, that this can occur in a organ-specific manner. So you can have an organ-specific coagulation disorder. And in ARDS, accumulation of polys in microvasculature, interstitial, and alveoli are key features. And this is proposed to cause unrestrained release of oxygen radical, proteases, as well as NETs. And in this lecture, so I've used this slide probably for the past 4 or 5 years in my DIC lecture now, and I always jokingly jab at my pulmonary colleagues that I believe ARDS is actually a hematologic disorder. And I usually get a bunch of eye rolls with that. But recently, with SARS-CoV-2 or COVID-19, the term pulmonary intravascular coagulation has now been coined. And it's very interesting because from my experience in DIC as a hematologist in dealing with ARDS as an intensivist, knowing that the leukocytes are very much interplaying with this disease process really continues to underscore how much hematology is involved in a lot of these critical illness disease states. So again, we need to remember that coagulative homeostasis is complex, it is dynamic, it is self-regulating microsystem, modulating and sustaining balance by feedback inhibitory control. The take-home point here is you need functional feedback inhibitory control. Without it, you develop this massive dysregulation. So why is there so much controversy now, if you've been reading the journals, in regards to anticoagulation for COVID-19 patients? Well, the sheer complexity of coagulation, particularly involvement as it relates to host defense against infection in immunology, is prodigious and can be quite overwhelming. When we try to simplify it to a single mechanism or a state that can be treated with a single medication, we're sure to lose that battle. The complexity, if you can remember back some of the other slides that I showed on the coagulation cascade, is so massively complex that we need to not only respect the complexity, but also try and gain an understanding for this specific disease state. Now, I've spent a lot of time reading journal articles, reading blogs, reading news reports, talking to colleagues from across the world when it comes into anticoagulation for COVID-19. And one thing that is very clear is the less experienced that a person is, the higher their confidence actually is in how to treat this disease process. But every expert that I've spoken to is able to throw their hands up in the air and say, this is unusual. I don't know. Now, just because there's not research into something doesn't mean you shouldn't do anything at all. But the importance of this slide is to recognize that as you gain competence or knowledge, or if you have a very in-depth understanding of the coagulation cascade, your confidence level actually drops significantly. And it's those people early on that have a lot of confidence but limited competence or knowledge on the subject make a lot of really bold and sometimes dangerous claims as to how we should treat this problem. I would advise everybody to avoid a lot of these Facebook groups because I have seen so many cures for COVID-19 up to this point that it's almost unbelievable. And everybody that posts this stuff is 100% confident that they know that this is it and this is going to cure it. But realistically, the experts that have that knowledge kind of shake their heads and say, you know what? This might work, but we really need to study it. And in the meantime, we should do what clinically makes sense for the patients. At this point in the slideshow, I'm going to go through several different journal articles. Some of these are going to be early articles that were among the first of publications. Others are going to be more expert opinion. Right now, what we have is expert opinion, or a group of experienced people who have come together and try to put out some type of consensus guidelines. Now, when we have randomized controlled clinical trials and data from these trials, we should shift our mindset. However, we should not, in my opinion, wait for this data to come forward when we know or highly suspect what we're doing is not adequate. Now, this does not mean that we get to experiment on our patients, but this means that we take that expert opinion, we take our experiences, and we do the best that we possibly can with the information that we have and put it into a clinical context for that patient and do the best treatment that we think is appropriate. This paper in JAMA, the clinical characteristics of 138 hospitalized patients with 2019 novel coronavirus from Wuhan, China. This paper was one of the first to really demonstrate that the D-dimer is something that we should be looking carefully at. Now, in this graph, you can see that non-survivors had a higher peak in the D-dimer compared to those that were survivors. And the other thing to notice here is that the D-dimer continued to increase days after disease onset. Now, a sharp increase in the D-dimer, particularly associated with an increased O2 requirement or vent settings, was considered or should alert you that it's a pulmonary embolism until proven otherwise. Now, some people took this information from this paper and said, well, if the D-dimer isn't increasing, then what I need to do is decrease the D-dimer, and that's going to improve survival. And that's probably not the best way to look at it. The way that you should look at this is that the D-dimer is an alarm bell going off that something is worsening. The patient clinically is likely or potentially worsening at this point. So the treatment should not be targeting a D-dimer, but should be targeting more aggressively the underlying illness, which then should decrease your D-dimer. From the same study, a different chart now looks at your coagulation parameters, and it's looking at your prothrombin time, your PT, your activated partial thromboplastin time, your PTT, as well as your D-dimer. And interestingly here, the prothrombin time actually shows very slight increases in that time, otherwise prolongation. Now remember, the PT and the PTT are time-based tests, so they're prolonged or they're shortened. Now in a prothrombotic state, where you're developing a thrombus faster, you would actually expect your prothrombin time to be shortened or decreased. You would not expect it to be prolonged. You would not expect it to take longer for a clot to develop in a prothrombotic state. Now in this study in particular, the PTT was relatively normal, did not show great prolongation. However, this one particular study, there are other studies that I'll touch on that did show an increase in the PTT with a little bit more explanation as to why pathophysiologically that is happening. Another publication by Tang et al. Looking again at the D-dimer, survivors are in blue, whereas non-survivors are in green. You can take away from this graph that again, non-survivors have an increase in this D-dimer compared to those patients who were survivors. Now again, this should be an alarm bell. This should be a surrogate for the degree of illness that you're dealing with in the patient. So I keep mentioning D-dimer, but what exactly is the D-dimer? How does the D-dimer develop? Well, the D-dimer is initially developed from fibrinogen, which is clotted by thrombin. And these fibrin monomers are produced, and with factor 13, they're now cross-linked. And this really helps increase the tensile strength of this fibrin network that is now developing. Now, as this process, again, needs to have a regulated feedback mechanism, you don't want this process to continue uncontrolled, you'll have plasmin, which is now in your fibrinolytic cascade, which will cleave these adjacent monomers, which have been cross-linked, and ultimately you'll get your degradation products, one of which is a D-dimer. So in hematology, what does a D-dimer actually tell you? Well, we extrapolate a lot from D-dimers, whether somebody has a pulmonary embolism or thrombosis ruled out. But realistically in hematology, what a D-dimer tells you is that the patient has functional factor 13. Now we can extrapolate a whole bunch of other information beyond that, but you need factor 13 to cross-link. If you do not have factor 13, you wouldn't cross-link and you wouldn't develop a D-dimer. So again, everything else beyond that little piece of information is truly an extrapolation. And I've had people ask me, well, if you're telling me that there's a lack of feedback mechanism and the fibrinolytic system is not as active as it should be, well then why do we have a D-dimer that is elevated? Why do we have a D-dimer that is skyrocketing? This is a prothrombotic state. You said that that fibrinolytic system is turned off. And to a degree, but remember, this is homeostatic hemostasis. You need balance. So yes, while the fibrinolytic system is not as active as we would want it to be, so you have this potential to have the prothrombotic state and develop thromboses, the fibrinolytic process is still active. It's not active enough to prevent these clots from developing, but it is active enough to still break down and produce these D-dimers that we see. So the line at the bottom, the hemostatic homeostasis line, let's say if that was truly balanced, and you can see again in this description that thrombosis is massively increased in the process, and fibrinolysis is trying to keep up but not quite able, but still active enough to produce those D-dimers. A little bit earlier I had mentioned that some studies have shown prolongation in the partial thromboplastin time, the PTT, and the relevance of that. Now, this study in particular identified lupus anticoagulant in 50 out of the 57 patients, or 87.7% of the patients tested had a lupus anticoagulant. This study looked at 150 patients total. 64 clinically relevant thrombotic complications were diagnosed in this subset of 150 patients, mostly pulmonary embolisms, and 28 out of 29 patients receiving continuous renal replacement therapy experienced circuit clotting. So this study is demonstrating this prothrombotic state, and at the same time, they've identified this positive lupus anticoagulant. Now, how could this be of importance for us? Well, if a patient is presenting to the hospital with a antiphospholipid antibody or lupus anticoagulant and they have a prolongation in their PTT, then initiating heparin could be challenging. Now, if a patient develops a lupus anticoagulant or an antiphospholipid antibody, you may be falsely reassured with your PTT that you are in fact anticoagulating the patient with, say, a heparin infusion, but you may actually not be. That patient may actually still be thrombotic or prothrombotic. Now, you may not have lupus anticoagulant, and you may have a PTT that falls into your institutional guidelines for heparin infusions, for example. However, you may still have issues with the CRRT circuit clotting. And again, this just goes to demonstrate this very interesting prothrombotic phenomenon that we're seeing. What is a proposed mechanism for why then could you have a normal or PTT that falls within your institutional parameters as normal? However, you may actually still be prothrombotic at that point. Well, in theory, if you have antiphospholipid antibodies, that will prolong your PTT. However, that prior study also demonstrated significantly increased levels of factor VIII. Now, if you have increased levels of factor VIII, that could drive your PTT down. Now, wherever that balance is between the antiphospholipid antibodies increasing or prolonging rather your PTT and your factor VIII shortening your PTT, it's quite possible that you can have a value that is normal or close to normal, but the patient is still very much prothrombotic. This is one study, and I won't spend too much time on this study, but when this study came out, I actually saw a lot of changes being made in recommendations, and I had a lot of colleagues reach out to me asking what were my opinions on this. Now, this study clearly shows that heparin users had a lower 28-day mortality than heparin non-users, as you can see in the red. The biggest issue here is that anticoagulation is not necessarily standard practice consistently utilized throughout China, whereas here in the United States, the vast majority of our hospitalized patients receive some type of anticoagulation. In my experience, at least, it's very uncommon in an adult who is ill, especially an adult who is critically ill, not to be on any form of chemical prophylaxis, where that is not consistent, that is not standard practice in China. And the reason for that is they have such low rates of interhospital DVT or thrombosis that they don't routinely use chemical DVT prophylaxis. This retrospective study published in the Journal of the American College of Cardiology, the Association of Treatment Dose Anticoagulation with In-Hospital Survival Among Hospitalized Patients with COVID-19. Again, this is a single institution study. It's retrospective with over 2,700 COVID-positive patients of which 782, 28%, received systemic anticoagulation. The remainder had received some form of prophylactic. Median time to systemic anticoagulation was 2 days, and the patients receiving systemic anticoagulation more likely to have required invasive mechanical ventilation, 29.8% versus 8.1%. But as we break down this data a little bit more, the mortality in the hospital, if you received anticoagulation, then your mortality was 22.5% at 21 days. Those that did not receive anticoagulation had a mortality rate of 22.8% in 14 days. Now, the big differences here, those that were receiving invasive mechanical ventilation plus systemic anticoagulation had a mortality of 29.1% at 21 days. However, if you were receiving invasive mechanical ventilation but not receiving systemic anticoagulation, your mortality was 62.7% at 9 days. So a big difference, especially in those patients that were receiving invasive mechanical ventilation. This study also looked at major bleeding. Now, major bleeding, one thing to note, has many different definitions when you start looking at different studies. But here they used a hemoglobin of less than 7 in any red blood cell transfusion, at least 2 units of red blood cell transfusions within 48 hours, or a diagnosis code for major bleeding, including intracranial hemorrhages, hematemesis, melena, peptic ulcer disease with hemorrhage, colon, rectal, or anal hemorrhage, hematuria, ocular hemorrhage, and acute hemorrhagic gastritis. Those that did not receive anticoagulation had a bleeding rate of 1.9%, whereas those that did had a bleeding rate of 3%. Now, when you break that down a little bit further, those on anticoagulation whom had bleeding events, 63% had bleeding after anticoagulation was started. However, 37% actually had bleeding before starting anticoagulation. And consistent with other literature, bleeding events were more common in intubated patients, in this study 7.5%, than in non-intubated patients at 1.35%. This study out of the Netherlands in the Journal of Thrombosis and Hemostasis looked at the incidence of venous thromboembolism in hospitalized patients with COVID-19. And it looked at the ward patients as well as the ICU patients. And you can see the cumulative incidence of VTE on the left significantly, drastically higher in the ICU population, those patients who are critically ill, compared to the ward patients. But interestingly, if you can see, just about 60% of this cumulative incidence of VTE by day 20 since admission. However, when you look at the chart next to it, the symptomatic, less than 40% of these patients had a symptomatic venous thromboembolism. So how is this important? Why is this important? Well, one, these patients were receiving some degree of anticoagulation, prophylaxis in this study. Now, they used nadraparin instead of enoxaparin, which is more common in the United States, and they did double their dose during that ICU stay, but it was uncertain where some of this data came from in regards to when the nadraparin was dosed or doubled. And they also had patients that had been transferred into their ICU during this time as well. However, the take-home points here is there is a cumulative incidence that increases dramatically, particularly in ICU patients, and a large number of them do not develop your classical symptoms. So you cannot necessarily wait for limb swelling, or you cannot necessarily wait for significantly increased ventilator requirements to tip you off that you need to obtain a PE study, a CTA for a PE, or lower extremity duplexes looking for DVTs. This study just helps demonstrate that you need to have a very low threshold in your mind for when you are going to step up that therapy from, say, a prophylactic dose to a true treatment dose, and to have some standardized way to do that consistently. This study out of 3 Indianapolis area hospitals suggests that routine venous thromboembolism prophylaxis may be inadequate in this hypercoagulable state that we're seeing with severe COVID-19. Now, this study, again, is limited to 3 Indianapolis area hospitals. It reported the D-dimer on admission, the D-dimer peak, as well as the platelet count. And to break down the study a little bit, there were 109 patients that were identified with severe COVID-19, and this was defined as oxygen saturation less than 94% with a respiratory rate greater than or equal to 30 breaths per minute, and a P to F ratio of less than 300. 31 or 28% of the patients developed venous thromboembolism. 26 patients while on routine chemical VTE prophylaxis, and 3 developed this while on full anticoagulation for other medical comorbidities. When broken down, isolated DVT was identified in 84%, an isolated PE in 3%, and a both DVT and a PE in 13%. The rate of VTE in this population with severe COVID-19 was estimated to be 2.5 to 5 times higher than the general ICU population. And this is 28% in critically ill COVID patients versus 5 to 10% in non-COVID critically ill patients. Other researchers have looked at thromboelastography for COVID-19 patients. And again, while I'm not going to get too deep into this study in particular, to the right side of your screen, you can see all the normal components that we monitor and are able to get results for during thromboelastography. Now, in patients who have severe COVID, compared to those patients who are quote-unquote normal, some patients are demonstrating this hypercoagulable state. So they form a clot very quickly based on the clotting time, the R time. They also have a decrease in fibrinolysis. So they're not breaking down this clot that they're developing or the thromboses that they're developing. This publication out of the New England Journal of Medicine actually identified patients with large vessel stroke as a presenting feature of COVID-19, particularly in the young. Now, we tend to assume that prothrombotic states is an increased risk for venous thromboembolism, but what we're starting to see now as well are signals that arterial thromboses can also be a presenting symptom or a complication of COVID-19. Now, we do not have enough data. We have a lot of opinions, but we certainly do not have enough data to understand why do some young people who have no comorbidities present with stroke-like symptoms, and why do other patients have a very mild illness, and other patients develop this massive venous thromboembolism disease as well. So these are really all interesting signals that are out there in the literature and things that we should be paying attention to, and that all certainly need much more in-depth study and evaluation. Now, one thing that should be a concern is potentially balancing the bleed risk with this thrombotic risk that we're witnessing, and that we should be very careful if we are initiating anticoagulation that we don't cause massive bleeding events as well. Now, this study from a French monocenter, it was a retrospective study as well, and this identified 92 patients. 40% of them had thrombotic events, and you can see what those thrombotic events were, either venous or arterial, but it also looked at hemorrhagic events as well. And it's certainly not a negligible number of patients that had a hemorrhagic event in the breakdown of those hemorrhagic events. Now, I think that this study is important for us because it should force us to tap the brakes a little bit. It should allow us to take a step back and say, okay, we know certain patients have this prothrombotic state. We know that they are developing venous thromboembolisms with routine DVT prophylaxis. So we should, through expert opinion, anticoagulate these patients so that we reduce their risk of venous thromboembolism. But we have to balance that with a bleed risk. Now, interestingly, at least from personal experience, we did do a form, and I'll show that chart in a few slides. We did increase our level of aggressiveness with anticoagulation, especially in critically ill patients with COVID-19. And we have not had major bleeding events that you would typically think of. So we have not had an intracranial hemorrhage. We have not had a massive GI hemorrhage with this new protocol. Now, we did have patients before the protocol was enacted that had a bleeding event, and we really took that into consideration when we were writing our new protocol. Interestingly, we actually seem to see problems with removing arterial lines, interestingly, and my suspicion for this, and I have to go back and actually look through all of our data, but my suspicion for this is the DVT prophylaxis that we're giving is administered sometime around 7 or 8 o'clock in the morning, and then the team rounds sometime around 8 a.m., and by the time they get to that patient and a determination is made to remove this arterial access is roughly 3 to 4 hours after administration of prophylactic heparin, or low molecular weight heparin, and that is the peak effect that you're seeing. So we might be removing arterial lines during a peak effect now that we're giving this twice a day as opposed to once a day in some of these critically ill patients. And we're going to be looking at just shifting that time from when we are removing those arterial catheters. So what are some of the takeaway points from this lecture? Well, D-dimer is a signal. It is a signal that this prothrombotic state is still occurring. To me, as a hematologist, as an intensivist, I want to utilize this signal in the best way possible to decrease the risk that they're going to suffer a venous thromboembolic event, such as a PE, a massive PE, or a DVT. And that will give me indication that I need to step up my therapy. Now, heparin resistance seems to be occurring in some patients, possibly more in critically ill patients, and likely due to increased heparin binding proteins such as vitronectin. And heparin resistance is defined as greater than 35,000 international units of heparin per day that is needed to raise your PTT to a therapeutic level. So for an average 75 kilogram patient, that is roughly 20 international units per hour of heparin. Also, almost counterintuitively, as we discussed, the D-dimer is increasing despite decreased fibrinolysis. Now again, going back several slides, this most likely represents a disruption in feedback mechanisms and the fact that you still have fibrinolysis occurring and creating these D-dimers, but there's still not enough fibrinolysis to prevent the complications from a thrombosis from developing. Early on, I was receiving some comments or concerned feedback from colleagues, and I actually received emails from some colleagues around the world saying, hey, what do we do here? This is not recommended. There's no recommendations out there for what do we do for anticoagulation in these patients. Is this experimental therapy? And I would disagree. I don't feel that this is experimental treatment by any stretch of the imagination. Now, this is not a jab at Lovenox at all, or the makers of Lovenox. This is a way to take a step back and understand the data for what you are actually doing. So Lovenox is proven for prophylaxis of DVTs in medically ill patients. I don't think anybody would argue that. But when you actually look at the package insert and you look at the research behind these statements, Lovenox treatment lowered the risk of DVT, which may lead to pulmonary embolism, and the outcomes of medical patients with restricted mobility treated with 7 days of 40 milligrams of Lovenox subcutaneously had a relative risk reduction of 63%. So contrary to common belief, this does not prevent DVTs or PEs. This decreases your risk in a normal, medically ill patient. I think we can all agree that COVID patients are not the norm of what we are used to seeing. Now also, directly from the package insert and the research behind Lovenox, at approximately 3 months following enrollment, the incidence of VTE remained lower in the Lovenox 40 milligram treatment group versus a placebo group. And they looked at major bleeding, which was roughly less than 1% for the safety endpoints for both Lovenox and placebo. So how does a hematologist, also intensivist, try to develop guidelines that we should be using in our intensive care unit? Well, there are a lot of guidelines out there, and a lot of them are really written with good intent. But one way that we wanted to think about it here is looking at the thrombosis risk, the bleed risk, and because of this signal in the D-dimer, we wanted to utilize that as well to help strengthen our opinion whether somebody should be anticoagulated or not. Now, I'm not going to go through these entire guidelines, and again, these are the guidelines that we are using for our intensive care units and our critically ill patients. And this is highly likely to change as we start getting information and data from randomized controlled clinical trials. Now, I am not suggesting that you use this anticoagulation guideline. In fact, I'm suggesting that you utilize whatever guidelines have come through your own institution. However, this is what we are doing, and so far we seem to be having a relatively good experience with this. This gives us a standard approach in how we are anticoagulating the patients, whether we are using prophylaxis, a high bleed risk, or full doses of anticoagulation, and how we are monitoring those. Now again, we have a heparin assay. We don't have a specific 10A assay, so some of the treatment parameters and the target levels are going to be different than a different institution. Using a 10A assay, you might be able to have a higher target level because, again, it's not a hybrid type of assay. So again, best to talk to your hematologists, talk to your pathologists, talk to your lab, the people that run these tests to determine what is the best level for prophylaxis and what is the best level for full treatment. And again, keeping in mind that patients who are non-critically ill probably don't need the same level of aggressiveness that critically ill patients need, we created similar guidelines with that reduced recommendation. And again, I am not showing these as a way for other institutions or people to take these guidelines and necessarily use them, but basically shows the thought process that we utilized in conjunction with hematology as well as critical care mindsets to come together how safely to anticoagulate these patients. And lastly, there is a lot of debate out there right now currently about should we use extended anticoagulation for patients. So these were some guidelines that we came up with. There are a lot of guidelines out there. There are a lot of recommendations out there, even from societies such as the American Society of Hematology, and most of them come down to consider it for your patient for reasons X, Y, and Z. But those reasons aren't necessarily very well defined. So I personally would recommend first thinking about their thrombotic risk. How critically ill were they, if they were at all in the hospital? And what is their functional status? Are they back to their functional status? Yes or no? And then at that point, determine what their bleed risk is. And there are lots of different calculators that you can use to determine the bleed risk. And based on all that information, decide whether or not you want to make a recommendation for the patient to go home on extended prophylaxis with one of the recommended medications. Rivaroxaban, 10 milligrams PO daily, is one of those recommendations. And somewhere from 30 to 35 days has been looked at for different medications. The most important thing here is not to start this medication and send the patient home. The most important thing here is to determine in your head whether or not you think the patient would benefit with limited bleed risk from this extended anticoagulation prophylaxis, and discuss it with your patient. Explain, we do not know currently whether this is helpful or not. We don't know if this is potentially harmful. And if there are randomized controlled clinical trials that you can enroll a patient in, then please, by all means, enroll your patient in these types of studies. This is how we gain the knowledge. But until we have that, take a look at your patient and decide. Now, I can say, in my experience, I get a lot of consults for this now, especially when the patients have been critically ill, and it's been a nice continuity of care, actually, because I've taken care of the patient when they've been admitted critically ill to the ICU. They've improved and transitioned to the general wards, and now they're getting ready for discharge. And I'm getting calls for consults about, do we send this person home on anticoagulation or not? Well, it's very easy if they're a low bleed risk and they had a DVT or a PE, but in the case where either you don't know whether they had a thrombosis or not, or their functional status is challenged at that moment, what is the best thing to do for that patient? So in those instances, again, I've sat down with the patients, I've laid out what information we know and what information we still are hopeful from obtaining, and give the recommendation. And every single one of those patients has basically just said, I've gone through so much. Do whatever you have to do to keep me out of the hospital again. And we've made appropriate decisions based on those conversations. So I work with fellows, pulmonary critical care medicine, hematology, and I also work with house staff. And as I've been giving these lectures, every now and then I'll get a question of, hey, Dr. Miller, you're a hematologist, you're a critical care medicine doctor. Where do you fall on this curve? And I can say early on when we started getting the information about this prothrombotic state, I was very confident in just saying, yeah, this is all we need to do. And then as more information comes in, that competence and knowledge really actually wasn't there. I was pulling off of prior experiences in hematology and prior experiences in critical care medicine. But I didn't have that experience specific for what we're seeing in COVID-19. Now, as I gain more information and read these hundreds of studies that are coming out, it's very clear that this prothrombotic state is something to pay attention to. Now, do I truly know everything that we need to do? Absolutely not. I'm making my decisions and my recommendations and writing my guidelines with the most information that I have available to make what I feel are the best decisions. And that's where we are right now with COVID-19 and how to treat this prothrombotic state. We have to do the best with the information that we have without going overboard and harming patients in the meantime. Again, this does not mean that we get to do whatever we want or that we get to experiment on our patients. I'm still having conversations with my patients of, hey, this medication, enoxaparin, 40 milligrams once a day, is what is recommended for critically ill patients or patients on the general ward. But we are not seeing normal things happen. We are seeing unexpected things. And therefore, we're making a potential recommendation of doing twice a day dosing at such and such a dose. And all the patients with that conversation seem very, very willing to take your expert opinion. I've also joked with my house staff, my fellows and residents, that you can be an expert in one specific area, but you're not immune to this Dunning-Kruger effect. Nobody currently is a world-renowned expert in what to do here. We have varying experts in hematology and in critical care medicine, and all of these opinions are extremely helpful, but we all have to take a step back and remember that at times our level in confidence may quite exceed the competence and knowledge. And it's important for us to recognize that so that we continue to find the best data available to make decisions for our patients. Some ongoing questions that I still have that I think about, that I thought about the past couple weeks when I was on hematology consults and while I've been on the ICU services. Is the D-dimer a marker of illness, a red flag, or a red herring? Well, very clearly, I think that it is a marker of illness and a warning. It is a sign that something is going on, that this prothrombotic state is there and probably getting worse. Ongoing question of how much anticoagulation. Well, again, like I've said, we put out our guidelines trying to use expert opinion and the best available information that we have to make the best decisions for our patients. However, we don't know if this is truly the best approach. We will know that when we have randomized controlled clinical trials. And I encourage everybody to enroll patients in these randomized controlled clinical trials so that we can be certain we are doing the best things. We don't know the long-term outcomes of anticoagulation. We don't know if treating somebody in the hospital during their hospital stay is the best for the patient. We don't know if they need a week of prophylaxis, extended prophylaxis after discharge. We don't know if it's based on their mobility levels or deconditioning. We don't know if they need 30 days of anticoagulation. And those are very individualized decisions right now. We're also not certain what to do when a patient moves from the ICU to the general floor. Do you de-escalate this therapy, this aggressive anticoagulation? Do you continue them on the home prophylaxis? And again, these are questions right now where we are getting consults in what to do. Now, I can say that if you trend the D-dimer, while it should not be your sole point that you make a decision based off, but if you see that a D-dimer is now decreasing and the patient's mobility has improved and their clinical status has improved and they're getting ready for discharge, it might be reasonable to decrease to a single once-a-day prophylaxis. However, if a patient is on therapeutic anticoagulation for suspected or presumed PE, it's imperative that you rule out and evaluate for that DVT or PE, because obviously that would change the dosing of the anticoagulation recommendation, as well as the duration of anticoagulation that the patient needs. Meaning, can you stop it when they go home, or do they need 3 to 6 months of anticoagulation after the diagnosis of this thrombosis? Some final thoughts. There is an association of a hypercoagulable state in some patients with COVID-19. Critically ill patients appear to be at a higher risk for thromboembolic phenomenon. Numerous coagulation disturbances result in a dysregulation and that prothrombotic state. And the onus is on us to do our best to ensure that our prophylaxis and or our treatment is adequate. And that should be done based on your own institutional guidelines. Treatments outside of standard should always be used in the context of a clinical trial when able. Until we have this information, continue to do the best that you are doing for your patients. Again, this does not give us a ticket to experiment on patients, but this does give us a reason to take a step back, ask ourselves, is standard prophylaxis or is standard treatment truly adequate? And if we don't feel that it is, then we should increase it to a level that we are more convinced that we are truly doing what we hope to be doing, whether that is prophylaxis or treatment. As time goes on, I hope that we continue to get this information and get this data available so that we can adjust a lot of these guidelines. The guidelines that I have shown you here are subject to change. In fact, they will change as we get this information and gain more experience dealing with critically ill COVID-19 patients. Always keep that in the back of your head. So if you're going to use another institution's guidelines, please look and verify that they are the most up-to-date possible. Do not rely on something from the past. Even information from a week ago may not be accurate for what we know now. Be very careful. For references that were not included directly in the slides, here's a list of some of those references. Thank you again for listening to this lecture. I really hope that my background in hematology as well as critical care medicine was able to provide some insight into this prothrombotic state that we currently are treating in COVID-19 patients, especially those patients that are critically ill. I've attached some of my information if you would like to reach out and get in contact with me, and I will do my best to respond and help you however it is that I possibly can.